Welcome to The Explainer. Today, we're diving into video capsule endoscopy. For anyone in medicine, you know there are some diagnostic puzzles that are just tough to crack. Well, this tiny camera is a huge part of the solution, especially when your standard scopes can't reach the problem. So let's kick things off with a situation you've probably seen or will see. You have a patient with a persistent GI bleed. You've done the upper endoscopy, you've done the colonoscopy, and they're both clean. It's frustrating, right? That's the exact moment where video capsule endoscopy, or VCE, steps onto the stage as your next best move.
So here's our game plan. We'll start with why we even need this thing, the small bowel blind spot. Then we'll meet the different capsules out there, talk about these super important safety checks, and follow the capsule on its trip. After that, the fun part, decoding the images, and we'll wrap it all up with the key risks and clinical pearls you'll actually use. Okay, first things first. Why did VCE need to be invented in the first place? Well, it all comes down to what we call the small bowel blind spot. Think about it. The small intestine is long, it's winding, it's just a really tough neighborhood for our standard scopes to navigate. VCE takes a totally different path. It's non-invasive, it just goes with the flow, tumbling along with normal peristalsis. And the view it gets is incredible. We're talking 1:8 magnification. You can literally see individual villi. That's a level of detail it was just impossible before.
So, what is this little pill-sized camera we're sending on this incredible journey? Let's meet the capsules, because it turns out there are a few different models to choose from. Here's a quick look at the main players you'll see in the US. You've got the pill cam, which is kind of the granddaddy of them all, evolved from the original capsule. Then you have some cool innovations, like the CapsoCam. Get this, it has 4 cameras for a full 360-degree view, but the trade-off is you have to retrieve it afterwards. And check out the NaviCam, it's already got an AI assistant built right in. And speaking of innovation, this is just brilliant. Some capsules, like the MiroCam, use this technology called electric field propagation. Instead of burning up its battery sending a radio signal, it uses the patient's own body as a conductor to transmit the data. It's just a really clever use of physics that saves a ton of power, which means a longer battery life and more pictures. Okay, now for one of the most important parts. Before a patient swallows anything, we have to run a series of pre-flight checks. This is all about making sure that little camera has a safe trip and we avoid any trouble. The absolute #1 thing we worry about is the capsule getting stuck, what we call capsule retention. So if a patient has a known stricture or obstruction, that's a hard no. Same goes for things that would stop the capsule from even getting started, like a swallowing disorder or severe gastroparesis. And here's a really key clinical update for you. Pacemakers. They used to be a big red flag, but now they're no longer considered an absolute contraindication. Now, some conditions really crank up that retention risk. For patients with known Crohn's disease, who can have all sorts of inflammation and narrowing, that risk shoots up to as high as 13%. That's about 1 in 8 patients. You absolutely have to respect that number when you're deciding if this is the right procedure. So for these high-risk folks, what do? We use this really smart solution called a patency capsule. The best way to think about it is like sending in a scout. It's the same size and shape as the real camera, but it's made of a material that just dissolves after a day or two. If it makes it all the way through, great, we know the coast is clear. But if it gets stuck, no problem, it dissolves on its own, which not only avoids a complication, but it also tells you, hey, there's definitely an obstruction here that needs to be addressed. Okay, so the patient is all cleared. What does the actual day of the study look like for them? Let's walk through the journey. Honestly, the procedure itself is pretty simple, and the patient can just go about their day. They start with an overnight fast, then come in, swallow the capsule, and get fitted with a sensor belt that's hooked up to a small recorder. After a couple hours, they can have clear liquids, then a light meal. Later that evening, they just bring the recorder back, and we download tens of thousands of images. It's that straightforward. The capsule's journey is over. Now for the payoff, sifting through all that data to find the diagnosis. This is where VCE truly shines. The numbers on diagnostic yield they speak for themselves. When you're hunting for the source of a small bowel bleed, VCE finds it about 63% of the time. Now compare that to a push enteroscopy at 26%, or the old school barium studies at a mere 8%. It's not even close. And when VCE does find the problem, what is it usually seeing? The most common finding by a long shot is angiodysplasia, those little fragile blood vessels. but it's also incredibly good at picking up on things like ulcers and even tumors that other methods can easily miss.
And that brings us to the next massive leap forward: artificial intelligence. Looking through up to 90,000 images takes a long time and a lot of concentration. But with an AI assistant that flags the suspicious frames for you, the average reading time plummets from 34 minutes all the way down to just 4. That is an absolute game changer for a busy clinic.
All right, let's pull all this together. We're going to focus on the single biggest risk and the most important takeaways that you need to lock in.
When we talk about risk with VCE, it really all boils down to this one number.
And that number is 1.4%. That's your overall risk of capsule retention. But here is maybe the single most important pearl of this whole explainer. Retention isn't just a complication. It's a diagnostic event. The capsule doesn't just get stuck for no reason. It gets stuck because it found the problem, a significant stricture or a tumor that you needed to know about anyway.
So let's wrap with these key pearls. First, timing is critical. In a patient with an active overt bleed, use VCE early to get your best shot at a diagnosis. Second, never, and I mean never, get a false sense of security from a normal barium study. It can miss strictures. Third, AI is your friend. It's going to make your life easier. And finally, always remember, a retained capsule isn't a failure. It often means you've found exactly what you were looking for.
This quote from our source material seems pretty straightforward, but the implication is massive. AI decreasing reading time isn't just about being faster. It's about changing the entire workflow, improving efficiency, and maybe even making us more accurate. And that leaves us with this final thought. As AI becomes a standard tool, what happens to the role of the gastroenterologist? It seems likely that the job will shift. Less time spent scrolling through thousands of images and more time spent on high-level interpretation, confirming what the AI found, and most importantly, deciding what to do about it. This little pill camera isn't just improving a procedure, it's truly reshaping a specialty.